This is Rural Health Leadership Radio.
Episode 185, a conversation with Dr. Steve Barnett, President and CEO of McKinsey Health System.
We have an obligation to try and manage this population and do a better job than we've historically done.
Welcome to the Rural Health Leadership Radio with your host, Dr. Bill Oxier. Each week, Dr. Oxier has a conversation with a different rural health leader to discuss what's working and what's not working in rural health, along with other topics of interest to rural health leaders. Rural Health Leadership Radio's goal is to improve health in rural America by providing a simple, no-cost means to share information and connect rural health leaders from around the country. And now, here's Dr. Oxier with today's guest.
Hi, everybody. I am your host, Dr. Bill Oxier. Welcome to Rural Health Leadership Radio. What would it mean to your organization if you improved on delivering quality? What if operations could be improved? And what about financial improvement? What rural health leader wouldn't want their organization to improve in any of these areas? And that is exactly why the Quality Operations and Financial Improvement Leadership Project for rural hospitals and clinics was created. It was created through a collaborative process with other very successful rural health leaders with the goal of assisting rural health leaders leading their organizations to thrive, not just survive. And it can be done, we know, because we've seen it happen. Now, our team is looking to recruit 2 new rural hospitals or clinics to participate in this program. So if you would like to know more, please send me an email to bill@billoxier.com. Today, I'm excited for our guests to share information to assist rural health leaders in best practices as it relates to chronic disease management, COPD in particular. Now, this interview took place a few months ago, and it was the final episode of a 7-episode series that the National Rural Health Resource Center put together for chronic disease management. And I want to thank them for allowing me to be a part of that and for making today's episode possible. So on to today's guest. Today, we're having a conversation with Dr. Steve Barnett, President and CEO of McKinsey Health System in Sandusky, Michigan. Welcome to the Rural COPD podcast, Steve.
Oh, thank you, Bill. Happy to be here.
Tell us about yourself. Who is Steve Barnett? What is your story?
Oh, boy. Been around for longer than I care to describe in terms of years.
You and me both on that one.
Okay. I've always been in healthcare. Started off as a respiratory therapist, actually, decades ago. Then went into nursing school, became a nurse, got a bachelor's in nursing from Oakland University in Rochester, Michigan, and really didn't practice nursing very long, but what I did do was pretty intense in a level 1 trauma center in Detroit, and then was admitted to a nurse anesthesia program in Connecticut, spent 3 years out there, received a master's, and then came back. I thought I was going to be happy just doing anesthesia, but I kept getting pulled into increasingly higher levels of administrative work, and that ended up resulting in me becoming the CEO of a critical access hospital. And I've been doing that since 2001. In a couple of different locations. And during that time, I went back and got my doctorate in healthcare administration. So it's been a busy career, I guess.
No moss grows on that rolling stone, Steve. You've had an interesting journey, continuing to learn and grow, and that's pretty cool because I know you're doing a great job at McKinsey Health System in the president and CEO role. So thanks for sharing this with us, and that clinical background, I'm sure, comes in handy sometimes.
Yeah, I find it often does. It really knocks down some, historical barriers between administration and those providing care, particularly physicians and mid-levels that I work with. So I think having that clinical background really develops a level of trust immediately that that not everyone enjoys. So I appreciate that.
Steve, why are you here with us today talking about COPD?
Well, COPD, it's a devastating chronic disease, and it seems to, I mean, I don't think it's really changed over time, but what we've found is that it seems to be rising in terms of afflicting populations in rural spaces throughout the country. So I think we have an obligation to try and manage this population and do a better job than we've historically done. And it seems that some of that attention is starting to get some traction, and hopefully we'll see more organizations in rural facilities across the country take on some of the pulmonary rehab work that we probably should have been taking on for a long time.
Now, as I understand it, your hospital is getting ready to start a cardio rehab program. Can you talk about that?
Actually, we launched that a week or two ago,
Okay.
And so it's up and running. And we're very proud of the fact that we were able to get a grant that allowed us to cover the cost of the equipment that we felt we needed to get started with the cardiac rehab program. And as you know, anyone who's had a heart attack, heart failure, or heart surgery can benefit from a cardiac rehab program. And studies, what we found, demonstrate that cardiac rehab helps both men and women, all ages, whether you have mild, moderate, or even severe heart problems. So an optimal program generally entails 36 one-hour sessions. Most programs run 2 to 3 times per week. And quite frankly, most cardiac rehab sessions that we'd be talking about are covered by Medicare and other payers. And in our case, the closest programs for cardiac rehab were an hour away. So the inconvenience of community members having to travel that far to attend a program is problematic, not to mention the fact that when they have to travel that far, their level of compliance with the program itself can come into question, particularly if transportation, which is often a problem, gets in the way. So bottom line, the program we felt was needed in our community. We were able to access some funding to support the equipment needs that we'd have to invest in. And we hope we're going to reduce the likelihood of those patients needing more extensive urgent care in the future.
Yeah, that's great that you're able to do that for the community, especially since they had to travel so far. Like you said, that impacts so many different aspects, just the fact that they have to travel so far. So that's great that you've added that service line. So now, how is cardio rehab related to pulmonary rehab?
Interestingly, both the space, the equipment, the monitoring, with the addition of monitoring oxygen saturation in the pulmonary rehab case, is all pretty much the same. And what we're really trying to do on the pulmonary rehab side is help these patients with chronic processes going on that really limit their ability to move and do many of the things that you and I would consider, wouldn't even think about.
Yeah.
Because of their shortness of breath related to the disease. So what we're trying to do is find out what they want, what is their goal, find out how much exercise they can tolerate, and then we begin in improving that exercise like any kind of program where you're going to improve your strength. And the intent is that at the end of the program, and the program really never ends, but at the end of the official side of the program, they have developed some strength and autonomy that they may not have had coming into the program. And most importantly, they have a better understanding, their knowledge of their disease process. And potential limitations are better understood.
Yeah, because as I understand it anyway, I obviously don't have the clinical background that you do, that, COPD doesn't have a cure, but through pulmonary rehab, you can definitely have a better quality of life. Have I got that right?
Yeah, that's exactly right, Bill. And quite often with chronic disorders, there are not cures. And what we're trying to do is make them as well as we can possibly help them become. And that improves their quality of life. And although we don't measure that very often, it's difficult to measure, it's significant, and so that's what we're targeting.
Yeah, and it was a great learning moment for me too, to find out, okay, if you've got a cardio rehab program, it's not that hard to start a pulmonary rehab program as well, since it does use the same equipment like you were just talking about. Now, it is my understanding, though, that pulmonary rehab is not a moneymaker. So why should, especially a critical access hospital CEO like you, invest in pulmonary rehab?
Well, you're right. It's not something that any organization is probably going to make a lot of money off of. At McKenzie, we changed our mission statement many years ago. Actually, very much aligned it with what was embedded in the Affordable Care Act. So that dates back to 2010, and we've been on that track ever since. So what we've been trying to do is develop processes that are aligned with transitioning how we deliver care at the organization. And our focus, because we believe that at the heart of this change in how we're going to deliver healthcare and drive the cost of healthcare down, is on improving health and only doing things that really add value to that concept of improving health and wellness, versus the old model that we've been stuck in for decades, where we were here when you were sick, you came and saw us, we did stuff to you, and then we sent you back home until you were sick again. So these types of services really add value to the members in the community, because we're working again on improving the health of the community, in the hope that will decrease the likelihood of them having any acute exacerbations of whatever the chronic disorder is.
I appreciate what you're talking about there, because the way I got to know you, I actually sought you out to be a guest on Rural Health Leadership Radio, because you, as the leader of your organization, you went where no critical access hospital had gone before, I believe, when you were one of the first rural hospital ACOs in the country. So I know that you have a focus on community engagement and well-being. So I'm guessing that all ties into what you were just talking about.
Yeah, boy, that dates back, it seems like, quite a while now. It's turns out that was 6 years ago, and there were 8 of us. Most of us were critical access hospitals that came together to establish that initial National Rural Accountable Care Organization. And we've been going down that path ever since. What we've learned over the years is that as we manage people and still maintain the quality, and all of that is measurable, we can actually trim a lot of the cost in healthcare out of healthcare. And so, to me, this is a natural next step to it's very much aligned with improving the health of the community and members in the community. And if we can reduce the likelihood of those patients having to come into the hospital or seek care that way, and they will at some point, but for the most part, we're going to reduce the likelihood of those acute episodes occurring if we can improve their health and improve their understanding of their disease and provide them with some strengthening that they maybe didn't have before. Plus, there's a social component to this that often gets dropped or lost that we're improving upon as well, because often chronic disease patients are very isolated. And so to bring them together and let them work with others who have similar problems, they all, the tide lifts all the boats, so to speak.
Yeah, absolutely. Because my impression is, particularly COPD patients that aren't getting pulmonary rehab, it is difficult for them to get out and about because when you're worried about taking your next breath, that kind of has an impact on things. So that makes a lot of sense, that what you're talking about there. So very interesting. Rural healthcare is known for innovation, and that often requires taking a risk, a financial risk, if you will, to live your mission. Can you talk about that a little bit?
Well, when we engaged in that activity, the Accountable Care Organization activity 6 years ago, we were doing it with a significant out-of-pocket cost because, as you may recall from our initial interview, a lot of the resources that you require or you will need to operationalize an accountable care organization are not readily available to organizations like critical access hospitals. And I don't think that's different regardless of where you're located in the country. So, and we weren't cash flush. I mean, we needed every dollar we were able to put together, but we felt it was important to incur that expense and start going down this path and finding out other innovative ways to develop those resources that can be shared across multiple organizations that look like us. So we took on that risk, that financial risk, and when everyone said, well, why, when you get paid fee for service, would you try to keep patients out of the hospital? Well, we felt it was the right thing to do, particularly and very much aligned with the Affordable Care Act. And it's clear today that we're not turning back. We're going to continue working on wellness and value. And that is the path to overall reducing the cost of care in this country. So we'll continue to make those investments. And what we've learned over the last 6 years is going to be very applicable going forward because, as you know, CMS and other payers across the country are now requiring, in whatever it is that looks like an affordable or an accountable care organization, that you begin to accept financial risk as well. So I think everything we've learned really prepares us for the future of where we're going and our ability to perform in that kind of healthcare finance model.
Yeah, it prepares us, but it's still got to be a little scary sometimes, isn't it?
Well, of course it is. But we have a culture at McKinsey that I don't even think it's arguable anymore. It thrives on change. It thrives on doing the right thing for the right reason at the right time. And it's just fun to watch people get excited about these things that they're able to do and bring to their community. You know, Bill, better than anyone, that just about everybody is related or knows somebody very, very well in a rural community, and that sort of thing, goes on wherever you go in rural America. So yes, they're taking care of people that are often related to them or they have long relationships with. So yes, it's about improving the health of that community, and that's what's so exciting.
Absolutely. That's one of the beautiful things about working in healthcare in rural America. So, Steve, if a CEO decided that they wanted to start pulmonary rehab, what resources does he or she need to start that service line?
Well, you can Google pulmonary rehab, and all of us use the internet today. So
yes,
it's pretty easy to find a number of sources. I'm not sure exactly what the professional association, I should know this, American Association for Respiratory Care, AARC, I believe, has information available on either starting up a pulmonary rehab program or can direct you to other sources. And I'm sure that you could find additional sources as well. There's also, if you're questioning whether or not this is something you want to do, or you don't understand the disease process very well, or you want to just get a general sense, you can always go to the National Advisor Committee for Rural Health and Human Services. And last fall, one of the issues that was worked on was COPD. So there's a fair amount of information there in the publications that one could access as well.
Okay. So in addition to those resources, what about staff? If you're going to start a program like this, are there recruiting issues, staff recruiting issues?
Sure. I mean, first of all, you need a physician champion. I don't think it has changed yet. I know that there's some movement to allow the supervision component of a program be extended to a nurse practitioner, but right now I believe it's restricted to a physician. So you need a local physician champion who believes in this, who is willing to take that role on. And what they will be supervising is the program overall, and the staff that are working in the program. They'll review the patient's charts for admission into the program, and they're available if there are any problems as an individual is going through the program. It's nice to have a respiratory therapist on staff, although I don't know that it's absolutely required. Frequently, PT and even LPNs and nurses, if they're schooled and educated appropriately, they can also be involved in a program.
So it sounds like you can, unless you want to bring in a respiratory therapist that you don't have on staff, if they've got the bandwidth, you can recruit existing staff to take on that responsibility, but you might need to bring in someone new. It all depends, more or less.
It does all depend, and I think the good news is, because respiratory therapists are difficult to find in rural areas across the country, we're lucky we have several here, but we had a period where it was difficult for us to find them as well. But if you can't recruit one, you shouldn't let that get in the way of necessarily investing in a pulmonary rehab program for your community.
Very good. So, Steve, what scares you the most about the future of COPD care?
If you've ever spent any time with patients who have a wide variety of pulmonary diseases, you can't help but be sympathetic to that experience that we've probably all had at some time in our life, where I think the common term is sucker punched, so all of the air is expelled from your body, it seems like, and you're standing there gasping to reinflate your lungs. Well, there's an element of that, not quite that acute, but there's certainly an element of exertion that goes into establishing every breath. And we don't live well without breathing well. So and oxygen is a mainstay of what we utilize to be able to do things. So you begin to lose your strength and your ability to even want to exist on the planet sometimes. So if there are simple things that we can do to improve the health of those patients, I think it's a worthwhile endeavor. What I fear is that organizations will not embrace that. I'm pretty confident just about any rural environment will have a similar number of patients by percentage that could benefit from the program. So it's needed everywhere, and it's just not as robust as it should be in rural America.
Well, thanks for sharing that with us. That's a good image and story that you painted there for us about what it's like to have a pulmonary issue. What gives you hope?
When you have a patient, we've only been at it on the cardiac rehab side for a couple of weeks, but I think many of the stories would be very similar. You see individuals who are often thin and frail. They quite often are carrying some sort of remote oxygen tank around with them, and every breath is an exertion. And when you see them go from limited mobility and limited ability to interact in social spaces to having mobility and being able to enjoy some of those family gatherings because they've learned more about their disease and they've developed skills to deal with it, that is what gives me hope, because that is exciting to watch, the joy that comes with somebody having that experience that they may have lost for a while. So yeah, it's an important program, and it can really help people.
Absolutely. The joy of doing what's right.
Exactly.
Steve, we've covered a lot of territory in the short time we've been talking here today. If our listeners only take one thing away from our conversation, what should that be?
Improving the health of your community often requires investment in services that may not have a significant payback financially, or at least it may not appear to be. But the payback in terms of the health of the individuals that benefit from those services is enormous. And if people believe that eventually we're going to be in an environment that really incentivizes you to improve the health of the community, then this is a good step to take now and go down that path.
Dr. Steve Barnett, President and CEO of McKinsey Health System in Sandusky, Michigan, thank you again for joining us today and sharing your expertise on COPD in rural America.
Thank you, Bill.
And thank you all for listening. If you enjoyed today's episode, please go to iTunes, Stitcher, Google Play, whatever your favorite podcast app might be, and subscribe to Rural Health Leadership Radio. And to continue the conversation of leadership in rural health, you can also join our LinkedIn group called Rural Health Leadership Radio. And while you're on Facebook today, check out our Facebook page. And we love likes. Until next week, let's keep working to improve rural health, one conversation at a time.
If you would like to connect with today's guest, please send an email with your contact information to bill@billoxier.com. If you would like to be a guest or suggest someone else as a guest, have a question you would like to ask, or simply want to contact Rural Health Leadership Radio, please use that same email address, bill@billoxier.com. That's BILL@BILLAUXIER.com. You can also visit our website at www.rhlradio.com.
And we'd ask that you please support our sponsor, the Dynamic Leadership Academy for Rural Health. The Dynamic Leadership Academy for Rural Health's mission is to improve rural health, one leader at a time.